We are back in Santa Monica with Ask the Doc. Doc, good to see you, my friend.
Nice to have you back in town, Dave.
It's been too long. We're
Yeah.
back. We got some questions from the fans. You ready to roll?
Yep. First
All right.
question is says, "Hey, thanks for your time. Our pleasure. My question is, what dangers, if any, are there associated with high DHEA sulfate levels in the blood as a result of TRT therapy? Um, and any suggestions to mitigate those issues?" So I've seen this occasionally. The first thing I ask patients is, what are you taking? Because sometimes these supplements, we all know that the industry is regulated, but it's just not enforced real well. Sometimes these supplements have DHEA in them, and there's three metabolites of DHEA, one of which typically doesn't show up on assays. I don't know if it's just too expensive. I never asked to get a 7 keto DHEA assay, but typically the assays that you can get pretty ubiquitously at the doctor's office, they'll include a serum DHEA and a sulfated DHEA sulfate. And what I found is DHEA sulfate tends to be the more stable number. And so the body likes to store it in a sulfated form. So it'd be nice to know what the number is, the assay for just DHEA serum, to see if it jives. And I typically get those two together to see what's going on. And I have my own process of trying to balance in my head what is the right amount. And honestly, while I'm going off on this long tangent, what is the right amount? I'll ask a patient, are you suffering from frequent colds and infections, a lot of inflammation, achy joints? And if not, then I don't pay much attention, or as much attention, to what would be considered lower than average levels of DHA and DHA sulfate. But yeah, my first question would be, are you slipping in some extra DHA inadvertently through some of the supplements? My second one is just a comment that, yeah, oftentimes, especially early on in therapy, especially if you've been depending upon the mechanism by which we can adjust for a lack of testosterone. So, one cool thing is the body will make more receptors, more locks for the same number of keys being, in this analogy, the testosterone. So that's the first thing. If you're short in testosterone, body can make, well, first, hopefully your pituitary will send a signal to testicles to make more, or in the case of a female, the ovaries. But if that doesn't work out, then the body upregulates the number of receptors. It also has another mechanism by which the adrenals will release DHEA, and DHEA can be converted down the line, as they say, in that cascade of hormones. Starts with cholesterol, then goes to, in broad categories, pregnenolone, DHEA, progesterone, testosterone, and estrogen. So early on, perhaps the body just hasn't adjusted yet and realized, hey, we got plenty of this, and you can see some levels that are higher than usual. And I don't know when this, it doesn't say if this is a male or a female.
Male, I think.
Oh, it is?
Mm-hmm.
But I don't know what the levels were when it's high. Is it just outside the reference interval? Which I don't know where they come up with some of these reference intervals, but DHA, from what I've seen in most laboratory assays, the reference interval is pretty reasonable. Not so for something like LDL. That's nothing close to normal, certainly, what I see. But I was going to say, in females, typically, we'll see this more often than in males, because it looks like, in my experience, females tend to depend upon that backup system a little bit more so than guys do. So that might be what it is, and there's all other issues to just throw in there, since we're considering different things. Laboratory error, assay to assay fluctuations. I'll see this, and it turns out, in 4 consecutive blood draws, it was just an aberrant number. The rest of them were all well within normal limits, but this one's a high one. So I wouldn't necessarily I wouldn't do anything really, except check to make sure I'm not taking any supplemental DHA I didn't realize I was taking, and just see what the next assay brings. So do we necessarily need to mitigate this issue? Not necessarily. One thing that I will throw in here too, since I'm going off on tangents, is My preferred form of supplementing, if someone needs supplemental DHEA, is 7-keto DHEA because it won't directly convert to another hormone that we don't necessarily want. The problem is like I said, I've never seen the assay on like a LabCorp list or a Quest list. I'm assuming it's either hard or too expensive to test for, but the studies will show typically that 100 milligrams to 200 milligrams, preferably divided twice a day for a female, will get to adequate levels or optimum, I guess I should say. And for males, 200 to 400 milligrams of 7-keto DHEA as a supplement. Again, without the assay, we can't really determine what's going on, and it won't show up as DHEA sulfate or DHEA serum. So it's one of those where you just kind of have to guess. But there's an advantage to it, obviously. And some studies show there's some thermogenic capacity to 7-keto DHEA for those that want to try and burn off a little extra fat. But anyway. The only thing I can think of is, and there's a presumption here that's a result of TRT therapy is, again, I think the term they used to use was, the hormones are getting backfilled as a result early on in TRT therapy.
Awesome.
Yeah.
Thanks, Doc.
Yeah.
All right, Doc.
So another question. Hey, Doc, I am 19 years old and have been training for around 45 years. I'm looking into taking some form of, and I'm not sure if this was...
Typo.
Yeah, type is some form of drama. I'm not sure.
We try to stay away from that.
Yeah, we try to stay away from the drama. Some form of, I think he says, might be saying drug or some kind of androgenic help to put on muscle mass. What is the best idea for this, and what is the safest and most mild SARM that can stack on some mass? I'm also trying to firmly steer clear of as many side effects as possible. Thanks. I'm going to assume this is a male too, even though I don't have a name and anyway. But yeah, for the most part, those are the guys that are trying to put on muscle mass, not necessarily female, but it could be. And SARMs typically are not taken by females for good reason. So a couple things here, and please don't shoot the messenger. You're asking me, and I'm just going to answer.
Yeah.
19 years old. Great that you're training for 4 to 5 years. Keep training. At 19, you're still forming the hypothalamic pituitary adrenal axis, and while we now believe it's more soft-wired than hard-wired, you want that to be established. And last study or textbook I read, that occurs somewhere around 26 years old. So to start messing around prematurely, previous to that 26-year-old mark, you're rolling the dice. Have I seen it ruin that HPA axis formation? Not that often, but
could happen.
It could happen, and I have seen it happen. Okay, so you're rolling the dice there. I am not a big fan of SARMs. I think I've said that many times before, simply because they have similar or sometimes worse side effects with fewer benefits.
People don't agree with you on that. I mean, the viewers, and you have a training in medicine and everything, but people are so hell bent that it's so much better and that there's no side effect, and that's what's out there.
Well, I have to plead some ignorance too, because like you say, it's not in my practice. Mm-hmm. A while ago, probably a decade now, when Osterine came out, a practitioner and I jumped on board. We were sponsored by the manufacturer of the Osterine, and we had patients who were willing to take it. A lot of athletes, including bicycle riders.
Okay.
And what we noticed, and the dosage was 25 milligrams, and I'll come back to that in a second, because that could be part of the argument. Well, you only did 25, you need to do 75. Mm-hmm. And I plead ignorance. But in that study, we saw a lot of abnormalities, none of which I necessarily care about. I tell me if you don't want me to go off on too far a tangent with the lipids again. But seeing the HDL drop doesn't scare me, because it's short term. It's going to bounce back, and as we know now, even though it's not propagated in the media that much, even amongst doctors, it's not LDL that's causing coronary artery disease. It's not making the plaque buildup. Unless you have extant coronary artery disease, then it'll help further it, just like gasoline around a spark will cause a problem, but the gasoline itself doesn't cause a problem. So having low HDL, the so-called good cholesterol, and high LDL, the so-called bad cholesterol, is not necessarily a bad thing. If that were the case, by the way, and I think I've said this before, all these people who are on ketogenic diets in this country who are consuming a large amount of saturated fats and have LDLs close to 200, okay, would be dropping dead.
Yeah.
Okay. It's typically a very long-term process anyway. So would you be rolling the dice somewhat if you did have unknown, it hadn't been established as, but you had it, you just didn't know it, coronary artery disease? Well, yeah, for the period that you're on it, 3 months or whatever, you would be furthering the formation of plaque. But that goes for anything. I mean, you should know what you're getting into. So find out if you have plaque before you do anything, including anabolic steroids, which have the same side effect profile, where every anabolic steroid is going to have an issue reducing the good cholesterol, the HDL, and increasing the bad cholesterol, as they say, the LDL. But again, since in my experience, anabolic steroids have a much better benefit profile, why would I want to go to a SARM? Now, I've conjectured that, especially being a registered libertarian, people don't want to have to go to a doctor. They like the freedom of, hey, I'm getting this on my own, and I can, chastised by a physician or whatever. I get that part of it, and that's, in my opinion, been a lot of the drive behind the SARMs. Now, that said, first of all, there are a lot of new SARMs, I think partly to justify the reaction, not that I'm having a reaction, but to respond to the voice of the bodybuilders who are using it, right? Or not, doesn't have to be bodybuilders necessarily, but there are so many new SARMs coming out that maybe, Austrian was one of the first ones. Maybe there are a lot more that have more benefit with the same side effect profile. Remember, they're still oral, and without the testing that I haven't seen any about the ones I know about, the RAD 140s, and I'm sure there's a slew of new ones, just like there's a whole bunch of new peptides out there, secretagogues and whatnot. But maybe the dosage is an issue too. And you have to use triple what it says in the box. And I hate to go down there and do the old double the dose and hope for the most thing, because that's, again, so my reticence isn't necessarily, particularly nowadays, that we don't have effective SARMs, but we don't have them tested. Yeah. So it's a roll of the dice. And this area, the gym guys, okay, the athletes, we'll say in a broader stroke, are great sources of data. Initially, some of the rationales behind how something's working are sometimes just crazy, silly, but the results are the results. And if you can tease out, guys that stack something, in other words, again, trying to get to the heart of the point of this, the gym or the athletic world is a place where a lot of these things, for better or for worse, get tested, and any athlete knows, hey, this works or it doesn't. I mean, guys, my generation that were using anabolics a long time ago, and listening to some of the propaganda, those anabolic steroids don't do anything. Really? Then how come I just increased my butt to the floor squats by 100 pounds in 1.5 months, right? So again, I all I can do, to cut to the chase here is I plead ignorance. But I also would like to say, fair warning. I mean, make sure as best you can at least monitor your blood work while you're doing this, and help collect some of the data, because we don't have it. We don't even have animal studies for some of these things. So,
I get it. That's a good point. All right. Thanks, Doc.
Sure.
All right, Doc.
So this next question asks, I recently saw questions answered regarding growth hormone and tendons, but I'm curious if there's any science promoting the use of growth hormone to treat cervical spine injuries. I was recently diagnosed with 2 herniated discs, C5, C6, and C6, C7, and cervical stenosis. I've found a bit of science, but it isn't peer-reviewed information. Thank you in advance for your time. Well, I can speak to this directly. Not that we need to hear about me, but I've had several spine surgeries and issues with herniated discs and all kinds of cervical stenosis. And the only thing that I can say is useful about growth hormone in recovery, and this is based upon the science as well as trying to promote growth hormone internally myself, is it helps with wound healing. Definitely helps with wound healing, and you'll hear surgeons who refer patients to us here at RSM say, hey, can you give them something, a secretagogue, to help them build growth hormone levels up to help them with surgery. But if you talk to the neurosurgeons or the orthopedic surgeons who perform the surgery, they'll tell you it doesn't speed the recovery of, I'm not talking about a laminectomy or something, but a replacement disc, okay, or a fusion. In that area, it doesn't speed anything up. Again, and I hope I'm not being confusing. There's a difference between the surgical wound where you had to cut through, because the lumbar you're spreading muscle,
and the actual
in the cervical you're
injury.
cutting, much more. So that can heal faster with growth hormone.
Okay.
But the bone healing stuff, I think the best thing you can do is your vitamin D, 10,000 IU a day.
Nice.
You can maybe double up for that time period.
Nice.
Most people are getting enough calcium, particularly those who are on TRT, by the way, because I think I've said this in the past, and what I've noticed in the study show, you're hoarding more calcium than most when you're on TRT or an anabolic. So that's really the only thing you should concentrate on, although there's nothing wrong with speeding surgical wound healing. But for a fusion or a cervical disc replacement, you're still going to be limited, particularly with a fusion, by that time period of healing. So, why spend the money? Why worry about surgical wound healing, which will happen a lot sooner? Okay.
It's a good question, though.
Yeah, I don't think you're going to see much on it. Partly because in this country anyway, it's illegal to prescribe except for 7 different disease states, none of which involve this. You know, so I don't think you're going to find much peer-reviewed information. But that's been my experience: is that it helps with surgical wound healing. That's all you're going to get out of it.
Awesome.